Hi, everyone. Thank you for joining us today to one of our last lectures in CT and cardiac MRI. It's a great pleasure today to have Dr. Viviane Taqueri from the Brigham. She's originally from Brazil, but she has completed all her training at Harvard and MGH and Brigham. She's the director of the Cardiac Stress Lab at Brigham, and she's an assistant professor at Harvard Medical School. She has published extensively on microvascular dysfunction, and today she will be talking about coronary microvascular dysfunction and emerging frontier in chronic coronary syndromes. Thank you for joining us and happy to have you here.
Thank you so much, Leandro. It's really my pleasure to be here, and it's really an honor to join this distinguished lecture series and to speak with you about coronary microvascular dysfunction, an emerging frontier in chronic coronary syndromes. These are my disclosures. And so the learning objectives for today's talk are threefold. The first is to recognize limitations in conventional diagnostic and management approaches for chronic coronary syndromes. The second is to describe how novel imaging tools are being used to understand prognosis of diffuse atherosclerosis, as well as coronary microvascular dysfunction in symptomatic patients. And thirdly, to consider management implications both for chronic coronary syndromes as well as coronary microvascular dysfunction, particularly in specific patient populations, including those who have a high prevalence of metabolic disease, non-obstructive CAD, as well as heart failure with preserved ejection fraction. As this audience is very well aware, we've been privileged to observe and live through, I think, a steady decline in cardiovascular disease deaths, which really reflects major medical and scientific advances over the last 60, 70 years, beginning with defining of risk factors and the growth of epidemiology, to the first description of bypass surgery, coronary angioplasty in the 60s, 70s, subsequently development of device therapies, including with implantable cardioversion and defibrillators. And then along with this came a parallel ability to non-invasively probe for disease, beginning with the humble Bruce protocol treadmill test in the 1960s, and moving through nuclear stress testing in the 70s, which became more and more advanced with the advances in positron emission tomography, as well as stress echo, and obviously CMR for viability in the 90s, and then most recently in the 2000s and beyond with coronary CTA. And so the conventional approach to cardiovascular risk stratification has really focused on, in many ways, simplifying binary definitions of disease, such that CAD becomes about obstructive plaque. Heart failure often has historically referred to low ejection fraction states. MI becomes simplified to a positive biomarker or troponin, and ischemia to a positive stress test. But we know that this is a simplification, and in fact, many times, even for research studies to look at therapeutic benefits, we lump patients into few categories as possible for treatment trials. And this is shown here, both in, as an example for the Jupiter trial, of rosuvastatin versus placebo in primary prevention, as well as subsequently the Improve It trial, which randomized patients to either simvastatin monotherapy versus simvastatin ezetimibe and looked at secondary prevention outcomes. So, as we've experienced, we have required larger and larger sample size, sometimes to demonstrate even more and more modest effects as all of our therapies have improved and the threshold for showing benefit has become more rigorous. Rather than using placebo, we now have excellent therapies. And yet, this illustrates that buried in these randomized control trial data is a real spectrum of patient response. And this is, I love this figure from Samia Mora's manuscript in the European Heart Journal, where she took the data from Jupiter patients and showed that, in fact, while most people actually did have substantial reductions in their LDL cholesterol on therapy, a minority of patients, interestingly, had no reduction or even an increase in LDL on therapy. And you can see that these patients actually demonstrated worse events. Similarly, in clinical imaging, we capture infinitely more data than are integrated currently into our daily practice. Again, from the simple treadmill test, which, with exercise can really provide a wealth of information in terms of duration of exercise, heart rate recoveries, as well as the physiologic response to stress. And along with that, we see, two-dimensional echo and now strain, as well as more sophisticated technologies looking at structure and function of the heart with CMR, with gadolinium for viability testing and for scar assessment, nuclear imaging techniques looking at both perfusion and metabolism, and then, of course, the improvements in coronary CT, which just allow tremendous ability to non-invasively evaluate the coronary circulation. And so, can we harness these data to better inform patient care and outcomes is really, I think, an interesting question about the future of so-called precision imaging. This is important because cardiovascular disease remains the #1 killer in both women and men. And in fact, we've seen a bit of a disturbing uptick recently in cardiovascular disease mortality trends in both women and men, which is likely multifactorial, but may reflect the fact that cardiovascular disease, as we have observed it recently, is changing. While angina and dyspnea remain very common presenting complaints to patients who come to us in our clinics, over half of patients, or up to half of patients seeking an explanation for their symptoms in the cath lab, no obstructive disease is found. And that includes up to 1/3 of men and 2/3 of women. And yet angina without obstructive CAD portends a much worse prognosis in both women and men in a way that's additive and correlative with the atherosclerotic burden, as we are beginning to quantify using advanced coronary CT techniques. And the diagnostic yield of testing can be quite low, even when we take into account traditional risk score categories like Framingham, or even simplified symptom characteristics, including the typicality of symptoms that patients present with. And in addition, the diagnostic yield of testing has decreased over time. This is partly because our volumes have gone way up, but may also reflect differences in the epidemiology of disease. And so, again, as we've experienced, despite substantial advances and decrease of smoking in the patient population, the rise of statin use, we are seeing an epidemic in obesity and glucose intolerance, which is really only getting worse. Our patient population is getting older. There are increasingly more female patients that we're seeing with cardiovascular disease. Traditional acute coronary syndrome presentations from large plaque ruptures causing big ST elevation MIs are going down. And yet hospitalization with secondary MIs and also with heart failure, especially preserved ejection fraction, are on the rise. And just to, again, emphasize how diabetes, obesity, hypertension, hyperlipidemia are just so prevalent now and increasing in incidence in our patient populations, not just in the US, but worldwide. I like to think about this, which is, from the ischemia trial, there was an unexpected finding in that ischemia with no obstructive CAD, or INOCA, is a real phenomenon, and in fact is common in women and in men. And just to talk a little bit about that, in ischemia, about 20% of patients who were enrolled, and as you know, were required to demonstrate moderate to severe ischemia on core lab verified reads, did not demonstrate obstructive CAD, even on sensitive evaluation using coronary CTA. And this included up to about 1,200 patients out of 6,000, half of whom were actually men. So I hope I've convinced you that we can no longer assume that a normal coronary angiogram implies a normal coronary vasculature. And furthermore, that conventional approaches to diagnostic testing, which were really designed for identification of obstructive CAD, can now lead to over-testing patients, but without differentiating who's truly at risk. And this is because obstructive CAD we now recognize is really but just one phenotype of ischemic heart disease and the so-called tip of the iceberg. But in fact, diffuse atherosclerosis that may be non-obstructive, as well as more distal coronary microvascular dysfunction may play an important role in prognosis. And in order to interrogate these disease processes, we need a more sophisticated toolbox that looks beyond just regional wall motion abnormalities and even just regional decreased perfusion to actually quantify blood flow in the heart, such as with coronary flow reserve. So in patients who have refractory angina, despite sometimes even optimal revascularization, or who have non-obstructive disease, CMD really may be the culprit. And again, it impacts the more distal coronary circulation, which makes up most of the resistive circuit in the heart and plays a very important role in normal myocyte function. But how do we evaluate it? And this really has been a major issue in moving the field forward over the last many years. The coronary microcirculation is much too small to be directly imaged in vivo and must actually be evaluated indirectly by perturbing function. We can do this through a variety of techniques, historically invasive techniques, but more recently, non-invasive techniques, with the gold standard being with PET, or positron emission tomography, nuclear myocardial perfusion imaging technique, has excellent accuracy, reproducibility, and has become the gold standard based on our evidence base for prognostic validation. The Covadis group recently published clinical criteria for suspecting coronary microvascular disease, and it basically boils down to three major concepts. The first is patients present with symptoms of myocardial ischemia, and these commonly include angina or shortness of breath, dyspnea. The second important consideration is that patients should demonstrate objectively absence of obstructive or flow-limiting CAD, ideally with an anatomic assessment, including a functional assessment such as FFR greater than 0.80, or a very highly sensitive non-invasive technique. And then thirdly, objective impairment in coronary microvascular function is defined by a CFR less than 2, an index of microcirculatory resistance, or IMR, of greater than 25, or potentially microspasm. To focus on coronary flow reserve, or CFR, which we can measure non-invasively with PET, it measures the integrated hemodynamic effects of epicardial CAD, diffuse atherosclerosis, as well as distal microvascular dysfunction on myocardial tissue perfusion. So it really integrates the whole circulation, and in the absence of obstructive disease, it reflects impairment in the more distal circulation. Very simply stated, it refers to the ratio of myocardial blood flow that we quantify at peak stress hyperemia, such as with a vasodilator stress, like we do with any typical stress test, over that at rest. And so you can see from a multidimensional cardiac stress PET protocol, which is basically a stress test, in 2 10-minute exams, you can obtain static perfusion information that allows for the visual quantification or semi-quantitative assessment of regional perfusion defects. We have gated information that allows for quantification of LV size as well as LV function. And then importantly, the dynamic piece through list mode imaging allows us to quantify blood flow in mils per minute per gram of myocardial tissue over the left ventricle. And so you can see in this example of this patient was able to augment her blood flow from rest to stress conditions with a coronary flow reserve value of 2.2. Based on observational data, we know that a preserved flow reserve, meaning essentially 1.9 or above 2, can effectively exclude high-risk angiographic CAD in patients who have non-severe amounts of ischemia and preserved ejection fraction with a very high negative pretest probability, you can see here, of 0.97. And we and others have now shown large number of studies, again, registry-based in multiple centers, that in patients who can at least double their blood flows from rest to stress conditions, and therefore have a flow reserve above 1.9 or 2, you see a very low annualized risk of cardiac mortality. But for those who can't, you see a steep rise in their cardiovascular mortality risk as the flow reserve values go down. And this may be from obstructive disease, or in the absence of that, it can actually be from a combination of diffuse atherosclerosis as well as microvascular dysfunction. These data show that impaired flow reserve, even in the absence of inducible ischemia, as well as independent of ejection fraction, can identify patients who are at high risk for cardiovascular death. So again, these are patients who underwent essentially had a normal PET study, cardiac PET study, which is a very sensitive test. And you can see that even those who have completely zero amount of ischemia quantified, if the flow reserves are low, that portends a worse prognosis for mortality. And furthermore, patients with low flow reserve, independently of their angiographic severity, can experience high rates of MACE. And you can see here that in patients who underwent both PET followed by coronary angiography for a clinical reason, for clinical evaluation of symptoms, those who had either a low flow reserve or a high angiographic severity score had the worst prognosis, but an abnormal flow reserve, even in patients who had essentially non-severe angiographic disease, still did poorly. And in fact, coronary flow reserve can modify the effect of early revascularization in patients with a substantial amount of ischemia, such that patients with low flow reserve who ultimately undergo revascularization, especially by CABG, ended up doing as well as those who had a preserved flow reserve to begin with. So these are very much exploratory or hypothesis generating data, but they are interesting to consider that perhaps impaired flow reserve may be a marker of CABG benefit, which is akin to diabetes or even syntax score, as has been shown in the large outcome studies like Berry2D, Syntax, and Freedom. We know that flow reserve can differentiate patients who have heterogeneous risk, including diabetics. So here you can see that in patients with no known CAD, but who had diabetes, if you stratify them further by their flow reserve values, those that are preserved flow reserve versus that have severely reduced, you can see that the patients with reduced flow reserve have much higher risks, whereas those who are diabetic but don't have, but have a more preserved flow reserve actually have lower risk akin to those who have no diabetes at all. And when severely impaired, we have seen that flow reserve can be even more prognostically significant in women, which is interesting. So I showed you before a stylized figure showing that as flow reserve values go down, the risk of hazard for cardiovascular disease mortality or other events goes up. Well, in fact, this is not a uniform risk for women and men, such that the effect of sex on cardiovascular events was modified by flow reserve because there were differences in outcome for women or men that were amplified, especially in patients with very low CFR. So the women seem to do worse in those categories of CFR that were in the severely impaired range. And yet this is despite the fact that in all patients with low flow reserve that we look at and we stratify by sex, women have much less obstructive disease overall. And this very much is reflective of many prior studies that have been shown that whenever you cath symptomatic women relative to men, there's a lot lower prevalence of obstructive CAD. Here, what we see is if we stratify the patients who have a very low CFR, less than 1.6, so becoming quite severe, and then we stratify by sex, most of the women who have low flow reserve are more in the non-obstructive CAD or one vessel disease category, whereas most of those men are in the multi-vessel or a single or one vessel disease versus non-obstructive disease. So among patients with low flow reserve, men had higher frequency of severely obstructive CAD, while women had higher frequency of non-obstructive CAD. But they all had low flow reserves and they had worse outcomes as a result. And this illustrates that there's actually a limited correlation between anatomic severity, here we define by the CAD Prognostic Index, and functional impairment by CFR. So the CADPI refers to angiographic disease severity, with 0 being non-obstructive or less than 50% plaques, and 100 being very severe, including severe left main disease. And what you can see is that there's quite a wide range of flow reserve values, even in those patients who have no significant stenosis, some being in the very normal categories and a substantial number being in the very abnormal categories. So we know that coronary microvascular dysfunction is actually quite prevalent, including both from non-invasive as well as invasive data that have been recently emerging. These data from our own center showed that in symptomatic patients who were referred for non-invasive studies with myocardial perfusion imaging with PET, out of almost 12 or more than 1,200 studies, you can see here that 2/3 of them were women, and that CMD was present in about 50% of patients, regardless of whether the patients were male or female. So that is to say, independent of sex, a low flow reserve, in this case defined as less than 2, led to worse outcomes in both women and men, even though this phenotype of essentially microvascular dysfunction, a normal PET perfusion study, but with abnormal CMD, is more common in women. And this was true, I should say, also for the subset of patients who had a completely 0 calcium score. This has also been shown in invasive registries where patients with angina or signs of ischemia who are referred for invasive coronary angiography, nearly 50% repeatedly have been shown to have no obstructive CAD, even when rigorously defined, including with FFR greater than 0.8. And then the majority of these patients, when subject to physiologic testing, do show evidence of coronary vasomotor dysfunction. Again, more than 3/4 of patients do, most of which is coronary microvascular dysfunction with or without components of vasospastic angina. We know from other studies, including from our group, that coronary microvascular dysfunction modifies the effect of a positive troponin on outcomes. And here you can see on a completely different end of the spectrum, when you take patients who had normal perfusion on PET, again, who would be otherwise considered to have a completely normal stress test and be ruled out for significant flow limiting disease, if you stratify by those who had a tiny detectable troponin at the time of their evaluation and those who had impaired flow reserve, you actually differentiate a higher risk group from an otherwise pretty normal subset. And it's really only the troponin detectable patients who had impaired flow reserve that experienced worse outcomes. And here, coronary flow reserve, which was reflecting coronary microvascular dysfunction, appeared to modify the effect of a detectable troponin on outcomes. Which is interesting because when you look at increasing data over the last decade, looking at the association of subclinical injury with markers, biomarkers like troponin, they seem to be better markers for future heart failure risk and cardiovascular death risk than they really are for big plaque rupture MIs. And this informed some of the subsequent work that we did that has focused on heart failure outcomes, where we, again, beyond looking at troponin, if you also look at diastolic dysfunction, coronary microvascular dysfunction modifies the impact of diastolic dysfunction on hospitalization for HFpEF. And really only the patients who had both an elevated E over E prime, pretty rigorously defined as above 15, and impaired flow reserves less than 2, had the highest risk of HFpEF hospitalization, and in fact had a greater than 5-fold risk, which is dramatic. We also know that coronary microvascular dysfunction is quite prevalent in obese patients. And you can see that flow reserve values go down with increasing body mass index, especially into the severely and morbidly obese categories, and serves as a better discriminator of cardiovascular risk than BMI alone, such that obese patients with CMD had a higher risk, even if they didn't currently meet the BMI threshold categories for bariatric surgery. So these data and others start to bring together a picture where, we can ask ourselves, can imaging better phenotype patients at variable risk for cardiovascular disease by identifying those with coronary microvascular dysfunction? And that may help us to better stratify patients for interventions, including non-pharmacologic interventions like bariatric surgery. So I wanted to move forward with a case to illustrate many of these points. This is a case where it's a real case, but she epitomizes a lot of the comorbidities that we see every day in our practice. So I'll take you through it and then would love to talk more in the discussion as well. So a 54-year-old obese woman with history of diabetes, hypertension, hyperlipidemia, and obstructive sleep apnea presented to clinic with progressive chest pain and shortness of breath. And she noted that symptoms were occurring with walking just a few blocks and appeared to improve within minutes of rest or after taking sublingual nitroglycerin. At baseline, she was quite sedentary and limited. She had a BMI of 44 with weight of 300 pounds. She was on several medications, including a baby aspirin, atorvastatin 40, lisinopril 10, atenolol 25, and insulin. And her electrocardiogram showed no acute ST segment abnormalities. She had a resting echocardiogram, which was described as a technically poor study, but did show mild LV hypertrophy, a preserved ejection fraction at 60%, and no regional wall motion abnormality. She'd also had a prior one, which had slightly better windows and had reported grade 2 diastolic dysfunction. She was referred for a vasodilator PET perfusion study. And what you can see here are the short axis stress pictures on top and the short axis rest pictures below. And you can appreciate that it's abnormal. And in fact, there's transient ischemic dilatation with a large and severe perfusion defect involving the LV apex in particular, as well as all the apical segments. Here you see the apex, the apical segments, and the inferior and septal segments, but with full reversibility, with a quantified sum stress score of 25 and a difference score of 25, reflecting again full reversibility and impacting essentially 37% of her LV was ischemic. The gated images also essentially confirmed the TID, which is to say that her rest LVEF went from 60% to 48% post-stress with mild global hypokinesis. And so given the concern, think about what you would do with this patient. Luckily, because we have PET, we can also quantify her blood flows, and let's see what those showed. So what we find is essentially that her rest flows are nice and normal throughout all coronary distributions and averaged over her ventricle. But her stress flows were severely abnormal. So stress flows, normal stress flows are in the 1.8 mil per minute per gram range. And you can see that as a result, her ratio of stress over rest was 1.67, or in the moderately abnormal category. So again, she had abnormal global stress flows with minimal regional variation and a global CFR of 1.7 or 6.7. So given the concern for the substantial amount of ischemia, she actually underwent subsequent evaluation. But before we get there on her cath, I should also note that the PET allows us to quantify a coronary artery calcium score. And you can see in her case, it was actually 0. So her invasive angiogram demonstrated essentially diffuse disease, both in the left system here and the right system here. And you can see there was a significant lesion, but it was quite distal. and doesn't really explain her large amount of ischemia. So overall, diffuse atherosclerosis. So in summary, this is a 54-year-old woman with history of diabetes, hypertension, OSA, and morbid obesity who presented with worsening angina and dyspnea, but at a low functional capacity, and had echo evidence of significant diastolic dysfunction, preserved ejection fraction. And her PET CT showed several things. The first, a large area of stress-induced ischemia over multivessel territory. She also had transient ischemic dilatation with a drop in her post-peak LVEF and severely impaired flow reserves and without regional variation. So these data together suggest that she has very high likelihood of diffuse disease that could also involve obstructive CAD. Despite that, her calcium score was 0, and her coronary angiogram showed no obstructive CAD. So, summarizing the data to date here, she does have coronary microvascular dysfunction involving multivessel territory with diffuse atherosclerosis, and essentially her disease is not amenable to revascularization. So how do we best manage a patient like her? A, reassure her and take her off her high-intensity statin because her calcium score is 0. B, perform a vasodilator SPECT when she inevitably returns with recurrent stable angina in 2 months. C, enroll her in the CERT CFR clinical trial, which I'll tell you about. Or D, A, B, and C, or E, none of the above. So just to get you thinking as we talk a little bit more about data in this realm. So what do we do for management in these patients? And the reality is that to date, there are no effective therapies that specifically target coronary microvascular dysfunction. And really the evidence base for management is lacking beyond symptomatic relief with anti-anginals, and importantly, risk factor reduction with aggressive secondary prevention in those who have atherosclerosis. Unfortunately, available therapeutic trials have been limited by variable patient selection, the lack of standardized diagnoses, small sample sizes, and insufficient demonstration of improvement. I wanted to highlight that PET allows for complementary roles of anatomic and functional imaging when we incorporate CT. And in fact, the assessment of atherosclerotic burden provides a very important and complementary and non-redundant prognostic marker of disease in these patients. And what you can see here again, when you even look at patients who have calcium scores of 0, those who have impaired flow reserves do have worse adjusted annual MACE rates. And it's this interplay of coronary microvascular dysfunction, CAD, and clinical risk that I think portends some interesting opportunities to think about new therapeutic strategies. So, contemporary evidence suggests that most of our patients with CMD also have macrovessel atherosclerosis, and this reflects the fact that they have substantial number of comorbidities, just as in that patient case example. Increasingly, we can assess the severity of atherosclerosis even non-invasively with tools like coronary CTA, and PET allows us to quantify the severity of CMD. So it's particularly in this group of patients who have non-obstructive disease, but moderate to severe coronary microvascular dysfunction that we may see potential opportunity to impact their care by considering new therapeutic interventions. And interestingly, there's a big overlap between women and men, but this may be a particularly relevant subgroup for improvement in outcomes in women. What evidence do we have to date that's exciting? CORE-MICA study recently showed durable outcomes at 1 year. So CORE-MICA took patients with angina or signs of ischemia who were referred for invasive coronary evaluation and had no obstructive CAD, but then underwent some pressure wire assessment of physiology to quantify, one, FFR to confirm that it was truly non-flow limiting disease, excuse me, as well as to quantify CFR and IMR. And then beyond that, they also did vasoreactivity testing with acetylcholine to quantify patients or to group patients into one of three categories. The first being vasospastic angina, the second being microvascular angina, and the third being non-cardiac chest pain. And what they showed is that the invasive testing linked to stratified medical therapy led to an improvement in their primary endpoint, which was a humble one, but an important one in our patient population of improving angina severity. And you can see here the anti-anginal and lifestyle modification recommendations that were made depending on whether patients fell into one of these three groups. So for microvascular angina, it involved a beta blocker, lifestyle changes and weight loss, certainly exercise, smoking cessation, and then the consideration of statin and ACE inhibitor. So I'm energized by the opportunity to think about the mechanistic phenotypes in coronary microvascular dysfunction, their overlaps, and what might lead to potential therapeutic strategies. So, when we consider the large range of patients that this could impact, emergently, we see new data coming from multiple groups looking at the role for coronary microvascular dysfunction, many of the issues that I showed you, including insulin resistance, kidney disease, patients with morbid obesity, with HFpEF, commonly in women, and in ischemia with no obstructive CAD, we can start to think about potential therapies targeting these patients that move beyond our traditional focus on obstructive CAD and low ejection cardiomyopathy with revascularization and device therapy to starting to deploy intense lipid lowering with aggressive statin use and even with PCSK9 inhibition. And then excitingly, with potential neurohormonal modulation using SGLT2 inhibitors, GLP-1 agonists, anti-inflammatory therapy, as well as gastric bypass, et cetera. So in the realm of anti-inflammatory therapy, in the time that we have left, I just wanted to share with you some data that we've been working on and been thinking about because we now recognize that inflammation is a key determinant of cardiovascular disease outcomes. This was a hypothesis for a very long time that has finally been proven to be true with very recent large outcome studies, including CANTOS, which looked at patients with prior MI who had an elevated hsCRP level and were randomized to an IL-1 beta inhibitor, canakinumab, versus placebo and followed for events. And Ridker and others showed that these patients did better over time. And these data have now been shown in a subacute MI patient population with colchicine in the COLCOT trial, and then very recently in chronic CAD, also with colchicine in LODOCO-2. And so we have increasing evidence that inflammation through the NLRP3 inflammasome and the IL-1 beta, IL-6, and CRP pathways can really impact cardiovascular disease outcomes. And yet the impact of the residual inflammatory risk at that interface between the vasculature, the coronary microvasculature, and the cardiomyocytes is not well understood. So we and others wanted to test specifically whether coronary flow reserve can be improved in patients who are enrolled in the CERT-CFR trial, which CERT was the cardiovascular inflammation reduction trial that randomized patients to either methotrexate at a low dose or placebo and followed them for events. CERT itself was stopped for futility because methotrexate did not have an anti-inflammatory impact on these patients that were enrolled. And specifically, this involved patients who had diabetes or metabolic syndrome, as well as atherosclerosis that was defined as obstructive disease in the past and had been treated. And yet, within that large outcomes trial, we were able to enroll in an ancillary study that was sponsored by the NHLBI, a group of patients who underwent evaluation with PET as well as echo and for biomarkers. And what we showed and data that we recently presented to the American Heart Association is that impaired coronary flow reserve was associated with inflammation and strain independent of traditional markers of cardiovascular risk. And in fact, the relationship between flow reserve and myocardial mechanics through global longitudinal strain and E over E prime was in fact modified by inflammation. And so, of course, these are, again, hypothesis generating, but and certainly large randomized trials will be needed to further test whether CFR can be used for patient selection or is potentially a target for effective intervention. But it really starts to bring home the possibility that we can use cardiovascular imaging biomarkers to better stratify patients who might benefit from specific therapies. So back to our patient and the question that I posed, how do we best manage her? So A, reassure her and take her off her high intensity statin. Her calcium score is 0. B, perform a vasodilator SPECT when she returns with recurrent stable angina in 2 months. C, enroll her in the CERT-CFR clinical trial. All of the above or none of the above. So let's go through these. And of course, the answer to A is no. She has diffuse atherosclerosis and is at high risk for future events. So we should absolutely keep her on a high intensity statin. And independent of calcium, we know that CMD and non-obstructive CAD often coexist and have associated poor outcomes. So aggressive medical management in these patients is really critical. B, perform a vasodilator SPECT when she returns with stable angina. We know many patients who come back to our lab and have repeat testing, which may or may not be completely normal, but they continue to return with residual symptoms. And sometimes even the ones whom we find a regional abnormality that's ischemic, who undergo PCI of a very focal lesion, may still return with angina. And so it's a challenge. But the answer here is no. There's low utility of repeated stress imaging in a patient like this. And conventional stress testing has quite a low sensitivity for CMD. And yet, on the other hand, excluding CMD in symptomatic patients who have normal testing by quantitative results can be quite a helpful tool to avoid unnecessary serial downstream testing and help patients better understand what their diagnoses may be. C, enroll her in the CERT-CFR clinical trial. This is an interesting one, right? We designed this ourselves, and we are thinking about CMD. But the reality is, in this particular trial, she was not eligible. So why is that? She was diabetic. So as I mentioned, the inclusion criteria required diabetes, but also with a history of obstructive CAD. And that reflected the larger parent trial CERT. So, to me, this underscores the need for enrollment of more patients like this who increasingly reflect our patient populations and include patients with non-obstructive CAD, but potentially with a high atherosclerotic burden risk, and women in landmark cardiovascular outcomes trials. So the answer, and then this is just to highlight again, the importance of, and many colleagues who have done a tremendous amount of work in this area, the importance of leveraging specific technology to probe relevant biology that may be particularly relevant in women, and then subsequently to invest in cardiovascular imaging research and clinical trials that include all of our patient populations, including women. And so as I mentioned, the answer here was none of the above, but we and others are starting to think a lot more about how to manage these patients. This is just an example from the Circulation Cardiovascular Case Series, where we took a different patient, but in many ways similar presentation, and a very talented fellow, Alex Schmeyer, and I walked through how to think about her management. So finally, to summarize our takeaway points for today's talk, 1, the focus on obstructive CAD and HFrEF is no longer adequate. Effective diagnostic testing needs to identify patients at high risk of events, not just anatomically obstructive disease, but without overtesting those patients who may be low risk, and then furthermore to aid in the development of needed evidence-based strategies for their management. Here are some key questions that I think about for cardiovascular imaging trials. It's about picking the right patients. It's about defining what our diagnostic goals are. And then it's about also defining meaningful endpoints along the anatomical to functional spectrum. So I often boil it down to these two questions. Would a diagnosis of CAD, not just ischemia, influence management? Versus in the setting of known CAD, would a diagnosis of the ischemic burden influence management? And regardless of whether we opt for a functional or an anatomic strategy first, unexplained symptoms in our patient populations do merit consideration of testing for CMD, which is quite prevalent. The European guidelines now have incorporated an assessment for microvascular angina using either invasive or non-invasive approaches. And then the third takeaway point is that characterization of the underlying pathophysiology is important so that we can better diagnose disease, define prognosis, and then ultimately tailor new management strategies to individual patients. Again, how I think about the pathophysiology linking coronary microvascular dysfunction to adverse ischemic heart disease events can be summarized here, where comorbid conditions, including obesity, hypertension, diabetes, chronic kidney disease, CAD, and the resulting inflammation may result in very low-level microvascular ischemia, which over time can contribute to impaired flow reserves, and then ultimately cardiomyocyte injury, fibrosis, and which may primarily impact diastolic dysfunction, a more highly energetic process, and lead to HFpEF outcomes and MACE, even in patients who don't have obstructive disease. The exciting part for me is that we have tools that can, again, interrogate each component of this proposed pathophysiology, and we can work together and collaborate so that we can hopefully move this field forward. So the future is exciting. Coronary microvasculature represents a new frontier in cardiovascular disease reduction. We now have the tools to actually move this forward with diagnostic and prognostic clarification of CMD in certain patients so that we can avoid costly, unnecessary, harmful additional testing, better define disease, and then develop the future evidence-based management that we need to improve our patients' outcomes. And this last slide I'll leave you with is really just summarizing the key point that there's a role for the coronary microcirculation in macrovessel disease prognosis, and it's that interface that it may be particularly relevant to many of our patients and where we should be thinking about focusing. So with that, I'd like to acknowledge my funders, as well as our vibrant cardiovascular imaging program. It's an amazing place to work. We have amazing trainees that come through. I know that you will be working with Dr. Aldo Scanone in the future, and he's just outstanding. What a pleasure it's been to have Aldo with us. And I wanted to thank Dr. Slipczak as well for this very kind invitation to give you to share a little bit of our work with you, as well as the things we're thinking about with coronary microvascular disease. So thank you. Happy to answer any questions.
Thank you, Viviani. That was great. I'll start with just Dr. Berman's comment. That's a superb lecture. I mean, what a great lecture, and so much future in cardiovascular disease, I think, is in this area. Please put your questions in the Q&A and chat. We'll go through them. I'll start with one question. Could you comment on the role of perivascular adipose tissue? Do you think there's any connection between that and microvascular disease?
Yeah, what a great question. So, you know, there have been great, interesting studies that incrementally show that pericardial fat may be associated with worse outcomes. And there's a lot of, again, hypotheses maybe relating, you know, endocrine adipokine type of signaling that may be impacting the coronaries. You know, what we're focusing on is actually looking at exactly body composition metrics, which we can define through the CT portion of the PET. And we have very interesting preliminary data that is looking at both visceral and subcutaneous fat compartments, but beyond that, skeletal muscle compartments, and the association with coronary microvascular dysfunction and outcomes. So these are data that we presented recently at the American Heart Meeting by one of our very talented postdoctoral fellows, Ana Carolina, who's currently in Brazil, but will be joining us for full-time Lehman Fellowship to come. So, so we're very interested in this space, and I think that you know, there are interesting parallels with patients who have non-alcoholic fatty liver disease, and maybe it will help us define kind of more healthy versus, less or more adverse obesity profiles in our patients.
Thank you. So from Armin Sadeh, a comment, beautiful presentation. He says, I'd argue, however, the presented case could have been more effectively addressed by a simple coronary CTA in the setting of diffuse, mostly non-obstructive disease and numerous risk factors, including morbid obesity, microvascular disease is likely and well explained in the patient's symptoms. Treatment should be directed at risk factor modification, GTMT. Invasive cath and costly PET would not be necessary for managing this patient, in my mind. Challenging question.
That's a great question, right? And so this is what we're talking about. So let's say, and I agree, I think coronary CTA can be an outstanding first test in certain patients. Let's say we had done the coronary CTA in her case, following, as the first step in the diagnostic evaluation with imaging. So yes, presumably we would have seen diffuse atherosclerosis, hopefully nothing in the intermediate range necessarily that would have required additional testing, but we wouldn't have known, right? We wouldn't have been able to quantify for coronary microvascular dysfunction. And so you would have been left with a patient who has non-obstructive disease. So maybe we could call her INOCA, right? Ischemia with no obstructive disease, although without the PET, you don't even necessarily objectively have definition of the ischemia piece. So I think what we're saying is there are multiple ways to approach these patients. Given her severe burden of ischemia and non-invasive testing with PET and the significantly reduced flow reserves, I think it is important in a patient with comorbidities to exclude for anatomic obstructive disease, right? Which again, if we revascularize, may lead to improvements in symptoms. But you're right, the most important piece is medical management. And certainly the ischemia trial has illustrated that point very well. But what I do want to add is that, coronary CTA does not allow us to necessarily diagnose coronary microvascular disease. And so it can be very helpful to objectively quantify disease in patients like her. You may argue correctly, right, that, she fits the bill for somebody who has coronary microvascular dysfunction based on what you've shown. And maybe that's the case, but we also see lots of patients who get referred to our center for evaluation. And when we test, a substantial portion of them don't have impaired flow reserves to explain their symptoms. And that can be also very helpful. So I think, what I would say is it's important to use the right tool to answer the right clinical question. And I completely agree that coronary CTA is a very helpful adjunctive tool. But it does not specifically evaluate or define CMD in these patients.
Do you think we're too far from quantifying with perfusion and CT microvascular disease?
Yeah, I think it's an exciting area for research, but we are not there.
Great. So from Dr. Travin, he says, should we incorporate STR stress blood with CFR, MFR when risk stratifying and guiding revascularization as per Lance Good's work? And he says also our PET quantification of blood flow values better than CT, QVF, FFR. So quantification by PET versus FFR CT when assessing for non-potential obstructive, yeah.
Another great question and one of emerging interest, right? I think it depends on, again, what your goals are. So FFR CT is also a potentially really exciting tool. It hasn't quite, it has a lot of limitations, as many of you know. Again, the way I think about PET and CT is really complementary, where CT often will use in lower pretest probability patients and PET will use in higher pretest probability patients. CFR versus FFR, they're really measuring different things, right? And so FFR is looking at a lesion-specific drop in blood flow or pressure that refers to whether that particular lesion is flow limiting, whereas CFR integrates that over the whole coronary circulation. And so Gould and others have shown that there's a lot of incremental prognostic value in integrating flow reserves, including the stress blood flows, as well as the flow reserve itself. And that's because, a flow reserve can be abnormal either because of low stress flows or because of very high rest flows. And we and others too, when we look at the patient populations who fall into these different categories, the patients who do the worst are the ones who have low flow reserves with both low stress flows and low rest and high rest flows. And then the ones who do the best are obviously the ones who have high stress flows and high flow reserves. In between, with those additional two categories, the ones who have a low flow reserve, but as a result of a lower stress flows, do slightly better than the ones who have a low flow reserve as a result of a higher rest flows. That may reflect a very different patient population, which includes many women, but they may just have a worse resting blood flow situation that impacts their ability to augment blood flow as well. And so again, a lot of the Bill Furon and others in the invasive world talk about the importance of using thermodilution methods invasively to define the index of microvascular or microcirculatory resistance, which does effectively the same thing. It helps differentiate those two patient populations. It is very possible that we will need different therapies for those two different groups of patients. But just back to the question about FFR versus CFR, it kind of depends on whether you're trying to understand the physiologic results of or impact of an obstructive lesion versus whether you're trying to integrate the impact over the whole myocardial, the whole LV myocardium or regional area of myocardium.
Yeah, very important to measure for the stenosis, right? Like you're saying for the FFRCT.
Exactly. Yeah.
Okay, we're against a lot of questions. Okay, so we'll try to go over them. Question from Dr. Berman. CCTA should have been an excellent study instead of ICA for non-obstructive CAD in evaluation of case example. Endothelial dependent CMD has been shown to be present in a substantial proportion of the INOCA patients. Could be a limitation of PET CFR.
The question is whether, what is the limitation of PET CFR?
Could be a limitation of PET. Yeah, what is the limitation of PET CFR?
It may be because of endothelial versus non-endothelial dependent dysfunction. I think it's a great question, right? So with PET CFR, we're using vasodilator or non-endothelial dependent mechanisms, whereas acetylcholine invasively can specifically interrogate endothelial dependent mechanisms. And so what many invasive evaluations are increasingly finding is that you can get impaired flow reserves from either of them. And many patients, there's a large number of patients who show non-endothelial dependent and may be, in fact, the primary driver. Although, you can still show that several patients have more endothelial or acetylcholine based abnormalities or have both. But what a lot of our interventional colleagues who do this say is that even for centers that are not doing acetylcholine testing for spasm, you can still get a big bang for your buck by focusing on adenosine and other vasodilator non-endothelial dependent mechanisms of defining CMR or a CMD.
That's great, thank you. And from Dr. Garcia, that he's asking, he says, great lecture. What is your opinion on the relative value of CMR detecting subendocardial ischemia, transmural gradient versus PET?
Yeah, I think CMR is another really great tool, which I didn't talk about, but there's emerging data and quantification of blood flow using CMR remains very much in the research space, but increasingly we're seeing more and more use of CMR. So I think it can be, great complementary technique. PET remains a gold standard just based on the amount of validation and in prognostic data from multiple centers.
Okay.
The nice thing about CMR, of course, is that the spatial resolutions is remarkable. And so it allows much better ability to understand structural abnormalities in the heart that may be contributing. And certainly, quantifying LGE in patients with MI-NOCA, MI with no obstructive disease, microvascular obstruction, post-acute coronary syndrome, and potentially T1 mapping for diffuse fibrosis.
What about from Dr. Osfeld is saying great lecture, and he's asking about the changes, so lifestyle changes. What's the impact of lifestyle changes on microvascular dysfunction?
Yeah, so no one's really looked in a very standardized way, but we suspect that that lifestyle changes would have very strong improvements in patient symptoms. Again, short of targeted therapy, it is something that we are recommending in conjunction with anti-anginal therapies as well as aggressive risk factor modification. And I think that there is evidence for the use of that multi-pronged approach from CORE-MICA and some of the WISE study group. They are actually evaluating some of these therapies in the Warrior trial, but often lifestyle will get grouped together with other interventions, so it becomes difficult to really tease it out. That being said, I'm a huge proponent for exercise, and it's something that we just do not value or help our patients achieve enough, I think, within our healthcare system.
Yeah, couldn't agree more. Just another question here. Does patient with CMD have high atherosclerosis with and without CAC? Looks like atherosclerosis is a confounder in the studies where CMD predicted events. How corrected for diffuse atherosclerosis is the question.
Yeah, it's a great question. So we do adjust for atherosclerosis as defined by plaques, right? But you're right that we can't really completely divorce that piece from the impaired CFR that we see. So when I refer to coronary microvascular dysfunction, it's really for impaired flow reserve in the absence of obstructive flow limiting lesions. So it absolutely includes patients with diffuse atherosclerosis. And as our technologies to quantify plaque burden get more sophisticated, probably with CT, then we'll be able to tease out those questions even more. But all of the outcomes data are adjusted for, all of the baseline comorbidities that we have access to, including any presence of flow limiting disease. These are often done in patients with completely normal PETs, which, as you know, is very sensitive for picking up flow limiting ischemia. And so the majority of these patients don't have, they don't have obstructive disease. But do they have atherosclerosis? Yes, many, many, many of them do.
In which of these ones do you just, to close, if you have to pick which patients you would do invasive acetylcholine testing, which ones do you think is the key? I know it's extremely underutilized in every hospital, I think, probably. So when is the most important to do it?
To do acetylcholine testing versus non-invasive, like flow reserve assessment?
Yeah, or to jump into the invasive testing.
Yeah, so again, I think it depends on the center expertise. So we don't do almost any invasive evaluations in our center because we have such a robust non-invasive program with PET. Again, acetylcholine based abnormalities make up a minority of patients when looked at more rigorously with all comers in these registries. Or these patient cohorts who have non-obstructive disease but have symptoms, and 3/4 of whom have abnormal CFR, the vasospasm is a very small component. And so I would say, I think a lot of this has to do with regional expertise. Non-invasively can be very effective because we couple that, right, with stress testing. Alternatively, if you're already in the cath lab and you see no disease, you don't necessarily stop there. And if you have the capability to assess via invasive methodology, CFR, IMR, and potentially do acetylcholine testing, I think that's a plus to help diagnose disease and then ultimately get patients to, better therapies. As opposed to what happens often, right? If you see no obstructive disease, you say, oh, the coronaries are clean, or historically we, right? but you don't really know. And now at least we are appreciating, again, from the CTA literature, that many of these patients have large amounts of atherosclerosis that's diffuse and they merit treatment. But again, even our guidelines refer to primary versus secondary prevention, right? Where do these patients fall? So there's a lot we don't know, but I think that the theme is that these more sophisticated imaging techniques are allowing us to redefine what we mean by disease. And as we get better in doing so, I think that we can better categorize patients and then potentially test therapies for them.
That was great. Thank you very much. Exciting lecture, and it will be in YouTube afterwards. And well, hopefully we'll see you in AHA in Boston, hopefully in person.
Sounds great. No, we would love to see you in person, and I really enjoyed the questions. Thank you, everybody. It's a little awkward, right? Not to see you in person, but you're such a lively audience with all of your questions, and I hope to meet you all in person someday soon. So reach out to me if you're in Boston, and I'd love to catch up.